Hi everybody, this is one of four sets of slides that I'm going to be doing screencasting as a result of what's going on with me and for Clinical Anatomy 1. So we've talked a lot about movements of muscles that causes flexion, extension, and so on and so forth. The one thing we need to talk about is what's called range of motion, and this is the examination of joints. So we have to remember we do have muscles that cause flexion and muscles that cause extension and external internal rotation, abduction, and so forth. One of the challenges is to look at a joint, whatever joint you wish, and recognize that what movements occur at that joint. So is it a hinge joint, a ball and socket, and so forth? And then recognize that if that joint is responsible for one movement, two movements, or many movements, that there are muscles that are responsible for all those movements. So there should be, when we examine a joint and its range of motion, because obviously these muscles and their influence on a joint, each joint in your body has a certain range of motion. In other words, how great or how many degrees of movement a joint can do in its specific movements. So we need to be able to look at those and measure them. And this is just an introductory because you're going to go into this very deeply in assessments and somewhat deeper again next semester. So when we look at examining joints, there should be an unchanging systematic approach to this examination. In other words, we want, if a patient comes and sees me or you or another therapist or one of your other teachers, we all do it the same way so that we all have the same outcome and there's no variation, shall we say. So there should be an unchanging systematic approach to the examination that varies only slightly to elaborate certain clues given by the history or by asymmetric responses. Now, what I mean by that is, when we look at the history here, we're saying what the patient says that they are unable to do. So you may sort of, let's use brushing your hair, for example. So when a patient wants to brush their hair, we have to think of all the movements that occur there. So what I'm going to ask you to do is stop the slide for a moment, and I want you to write down, thinking of the shoulder and the elbow and the wrist, what movements need to occur in order to brush your hair. So please stop the slide for a moment, write those down, and then come back again. Okay, so if we think about combing your hair, if we start with the shoulder, we need abduction and external rotation. We need elbow flexion, and we need wrist flexion and extension along with what's called ulnar and radial deviation. So all those things need to occur. Now, you don't need to remember those specifically, but what you need to understand is, in order to comb your hair, you require your shoulder, your elbow, your wrist, and your hand. So within the context of those mechanisms, if a patient comes to you and says, I've got pain in my shoulder, and you say, tell me some of the things you can't do, and the patient says, I can't comb my hair, and the shoulder's the problem, now you need to understand abduction, external rotation. Okay, maybe there's something that's going to be limited there. And you would expect to see that in the range of motion, that maybe there's limitation in abduction, or maybe there's limitation in external rotation. The other thing is, when we say asymmetric responses, is that when you look at them moving both their good shoulder and their bad shoulder, the bad shoulder doesn't function as well as the good shoulder, so asymmetrically it's not working properly. So as the movements are tested, the therapist is looking sometimes for the client's subjective responses and sometimes for clinical objective findings. In other words, a subjective response is pain. So the patient might say, oh, when you ask me to do that movement, it hurts. And when we do objective findings, that means that when you watch the movement of the joint, you recognize there is limitation in that joint movement that's measurable. So why do we do range of motion? Why do we need range of motion testing? Or why do we need range of motion at all? Well, the first is to perform activities of daily living, and you're going to hear that a lot coming up. Combing your hair is an activity of daily living. Vacuuming, washing dishes, walking up and down stairs, putting on clothes, so on and so forth. There are many things that we do in our day-to-day lives and our activities of daily living. And in order for us to be able to do those activities of daily living, we need normal ranges of motion in many joints. We also need range of motion to meet functional requirements. So it could be something we have to do at work, or play or sport, we have to have certain ranges of motion in order to functionally perform tasks. So what is range of motion? Range of motion is the evaluation of movement, and it determines, first, initiation of movement. Can the patient initiate that movement? Secondly, observing normal range of motion. So quite often what we do, if the shoulder, let's stay with the shoulder. The patient says that they have pain in their right shoulder. Well, the first thing we're going to do is watch the left shoulder work because there's no problem there, so that we get a sense of what's normal, and then we compare it to the bad side. Identifying abnormal ranges of motion. So again, the right shoulder, we look at the left, we got the normal. We have the patient start moving the right, and we see that there are problems there, that maybe they're limited in abduction, maybe they're limited in flexion, maybe they're limited in external rotation. There are abnormal ranges of motion, but there are also what are called pathological ranges of motion, and these could be things that are of a more serious nature. Could be a fracture, could be a ruptured tendon of a muscle, and so forth. Again, I'm not going to go deeply into this, but I'm just giving you the understanding, giving you examples of it, and you're going to get into this a lot deeper as you move through. So when we identify pathological, first is the two bones that make up the joint. How are they? Was it one not formed right? Is it eroded away due to long-standing arthritis? Is it just like me, you blew a patella and broke it, and you can't have normal range of motion because it's all broken? Integrity of the joint. So are the two bones in the joint, are they well fitted together, or are they, due to circumstances, not relating well to each other, so they're incongruent, and therefore the integrity of the joint is not there and not allowing for full range of motion? The other thing that we need to think about in range of motion is flexibility of the tissues. If you do an arm curl, just a normal arm curl, you have to have a certain flexibility of triceps in order to allow that flexion of the arm curl to happen. If there's significant scar tissue that limits the lengthening of the triceps muscle, then flexion at the elbow won't go through full range of motion because it'll be limited by triceps. So when we look at range of motion, we also have to think about what systems are involved and what systems could be the problem. So the nervous system obviously is involved in range of motion, control, and structure. The muscular system makes sense because it crosses the joints. The cardiovascular system, of course, it's the one that's supplying metabolites and oxygen and so forth, the muscles, to work in the first place. The joint surfaces themselves, as I alluded to, maybe they don't relate to each other well, and they don't fit well. The capsules, so as we know, synovial joints are all surrounded by fibrous capsules. If there's any damage or scar tissue within that fibrous capsule, that too can limit range of motion. Ligaments, holding elements, if they're not doing what they're supposed to be doing, that can change range of motion as well. The fascia itself that's involved in the muscles and all the structures around the joint can also have an influence on range of motion as well. So what can limit or increase range of motion? Normal or abnormal muscle length. So is it too short or is it too long? The joint capsule, as I said, is it tight and is it limiting? Ligaments, are they functioning properly, or maybe one has been torn or ruptured and therefore we have excessive range of motion, for example, in the wrong way, of course. The joint surfaces, again, if they're not lining up well, they won't allow for normal range of motion. The joint shapes, so if something altered the shape of one of the bones within the joint, which is going to result in decreased range of motion as well. So when we look at the types of range of motion, we have a couple of them. The first is called active free range of motion, active free. These are the movements that are produced by the patient's muscle contraction. So you kind of started on that road now by doing active range of motion. So this is when you ask your patient to do particular movements at a joint. So it's produced by the patient's muscle contraction. Therefore, it is the movement that is performed by the client when we're testing active range of motion. The second type is active assisted. We don't normally test muscles using active assisted, but it can be used if necessary when we're sort of measuring weakness or muscle strengthening. So this is if the client cannot move a limb without assisting themselves. This is usually a sign of either weakness or pain, and you need to investigate further. When we look at pain, pain limits function and it very much influences function. If something hurts badly, a patient will not move into that pain, therefore it will limit range of motion. Active resisted, you've already started. This is what we call strength testing. And of course, this is used for testing the strength of contractile tissues. It can be used to test nervous innervation. So obviously, the nerve that supplies the muscle, if there's something wrong with that nerve near the muscle, or even something that's wrong with that nerve at the spinal column, then that can affect the strength of a muscle because it's not getting enough innervation. In other words, active resisted tests nervous innervation of a muscle. Active resisted also assesses for lesions in muscle and tendon, and then you'll get into that later. The client is asked to resist isometrically with the segment in the neutral position, and the force that will be placed is by you, the therapist. So that's how we do it. And this is, again, just a review of strength testing or active resisted, which you have been doing in this semester. Since these tests give information on the strength of the contractile tissues, they can be used to help determine both neurological dysfunction, is the nerve not working properly that serves the muscle, or is it a musculotendinous pathology which is limiting as well? And you'll get into that a bit more next semester. Passive range of motion. Passive range of motion is the movement of a segment within the unrestricted range of motion that is entirely done by you as the external force. So we do active range of motion. We ask the patient to perform the movements. And then we traditionally do passive range of motion, which is you, the therapist, doing the movements that you've asked the patient to do. You haven't done passive yet, but you will be doing it next semester. So we have active, passive. Of course, we have active assisted as a time range of motion if we think that there's weakness. And of course, we have muscle strength testing or testing of strength, which we've been doing this semester as well. Differences in active and passive range of motion may be caused by muscle contraction or spasm, muscle deficiency, neurological deficit, or contractures or pain. So we are within this passive and active movements. This is what we're looking at. Is there spasm? Is there muscle deficiency? Is there neurological deficit? Is there contractures? Or is there pain that's causing it? The therapist should observe that passive range of motion. So you're observing when you're doing it, where in the range there is an onset of pain or restriction. So within the range as you're moving it, where does the patient say, ow? Or where does the patient say it can't go any further? Number two, how the point of onset of pain or restriction compares to active. So maybe they can get to a certain amount of abduction actively before the pain, and maybe you can go a lot farther before the pain when you do it passively, and that's going to mean something in particular. Again, you'll be kind of covering that next semester. Number three, how the affected side's range compares to the unaffected. So when we do active and passive on the good side, again, they came in with a right shoulder problem, and you're testing the left because you know it's normal. How does the right compare to the unaffected left side? And that helps build something for us to work on. So joint movements that we measure, of course, are flexion extension, ABA deduction, internal external rotation or medial lateral rotation, lateral flexion, and pronation supination. When we look at flexion extension, this is the shoulder, the hip, the knee, the elbow, the wrist, the fingers, the neck, and the trunk. When we're looking at abduction and adduction, this is the shoulder, fingers, and hip. Internal external rotation, this is, of course, is the shoulder, the hip, and the C-spine of the neck. Lateral flexion is the neck, the C-spine, and the trunk, the L-spine. Pronation and supination only occurs at the wrist. Protraction, retraction is the jaw, the neck, and the shoulders. Plantar flexion and dorsiflexion is what we measure or look at in the ankle. Inversion and eversion is the foot. Depression and elevation can be the shoulder, looking at the scapula, or the jaw, looking at the TMJ. Deviations at the wrist, so we have ulnar deviation, which is the hand moving to the ulnar side medially, or we have radial deviation, which is the thumb moving outwards laterally towards the radius on the forearm. Opposition, of course, is the thumb. Opposition is the thumb moving towards the little finger. Okay, thanks for listening to this. There are 3 more to come, and grab those as well when you can. Thanks again. Mm-hmm.